Hi, good morning, everyone. Let's begin another chapter of our series. Now, this is very important and very interesting also, and it's easy also. And I have seen questions come from both of these topics, and they are as such direct questions. But there are few tricky things, few tricky parts which we need to understand the concept of, so that in any form the question comes, we are able to answer that. So let us begin. So this is the topic portal vein embolization and ALPS. So let us begin. Now we all know why. Why do we need these two entities? Why do we need these two entities? Because in a day-to-day clinical scenarios, we see many patients who are in need of liver resection for their various conditions, HCC, CRLM, and major cholangiocarcinomas. And to achieve an R0 resection, they need an extensive surgery, extensive liver resection. Now, I had already discussed you, we cannot resect liver. Should be a like sufficient FLR. We cannot just go on resecting it, go on like removing the parenchyma. We cannot do that because the body will not be able to the liver will not be able to support the body if the remnant is small. So what do we do now? Should we do an R0 or R1 resection or an R2 resection? That is exactly equivalent to like not doing anything, okay, in terms of liver cancers and all. So we need R0 also, we need to preserve liver also. So these two techniques are like they have now helped us to achieve resectability because they over the period of time of 3 to 4 weeks or 3 weeks, they gave us an increment in the FLR so that after some time we can sufficiently remove the tumor and spare an adequate amount of liver tissue in the body so as not to reach the stage of post hepatectomy liver failure. Okay, so that is the main aim of these two things, to prevent PHLF, post hepatectomy liver failure. Okay, post hepatectomy liver failure has been defined by many definitions. But remember this: any deterioration in the liver functions, any liver functions like synthetic, biochemical, or things like that. So that is known as PHLA from the previous day. Okay, and it consists of mostly bilirubin, INR, and those sort of things. So I'm not going into detail of those because PHLF is an entirely different topic, and I haven't seen any questions asked from PHLF as such. So we'll be focusing on these two topics because these are easy also, and questions have been asked from this almost like one or two questions have come in in each year in one exam or the other. It has been asked, so it's interesting. Please let's go into the slides. So liver resection is the mainstay of curative therapy for various liver related conditions. The mortality is now 3.2 to 7%, but at present it is even less than around, it's around 2 to 5%. Okay, it has come down significantly because of the major advancement. And in the non-injured liver, and 32% for patient with cirrhosis. Actually, this is a very generalized statement. This cirrhosis is divided into CTP A, B, and C. The maximum mortality is seen in CTP C. It can even reach up to 40 to 70% has been defined in CTPC if we do liver resection. In A, it's similar, it's almost same as a non-cirrhotic liver. So less than 10%, less than 5, yeah, 5 to 7%. Okay, that almost like averages comes down to 30%, but uh, it's all dependent upon the CTP score. Most cases of mortality attributed to post-operative liver failure or post-hepatectomy liver failure, what I told you, PHLF. FLR is a strong and independent predictor of post-surgical hepatic dysfunctions. And portal vein embolization and ALPS both are useful in this. So portal vein embolization is a safe image guided procedure that causes hypertrophy of the FLR by redirecting the portal blood to the non-tumor bearing liver. So you see, this is the liver, this is the tumor, and this is we need to remove the like this is the tumor. We need to do a right extended, and we only have left lateral. So what we do, we embolize this right portal vein. So now all the blood is directed to the left portal vein and its branches. So because it receives more amount of blood, this grows. So ultimately this atrophies. So it becomes something of this like this. The ratio changes. Okay, this becomes increased, this decreases, this portion decreases, and we can safely resect this part, and we are left with an adequate FLR. So this is the simple concept of portal vein embolization. So moving on, it causes a hypertrophy of the liver remnant so that 78 to 80% of unresectable patients can undergo a major hepatectomy. So it converts like almost three-fourth of patients, 3/4 of all unresectable patients are converted to resectable. So this is the efficacy of portal vein embolization. It's 70 to 80%, 78 to 80% it is efficient. Okay. And the frequency of insufficient hypertrophy is only 0.6 to 3.6%. This has been from various studies, but uh, and see, we have only seen in a clinical setting very rare cases for insufficient hypertrophy, and most of them usually do that. So, but this is given in literature, so this term there is not 100%. So we need to remember 0.6 to 3.6% portal vein embolization does not result in a sufficient hypertrophy. So this is just for a basic understanding what is the mechanism of liver regeneration. I have already discussed in a previous lecture the mechanism of liver regeneration. I am not going into detail for it. I just wanted to tell you that portal vein is a very important thing for liver growth. Portal vein carries blood, which carries hepatotrophic factors, and the changes in the liver, the changes in the liver during the hypertrophy phase are reflected by the changes in the portal vein flow also. In animal models, like it has seen that growth factors are carried by the portal vein. And Doppler studies have also shown that the timing of regeneration correlates with the increase in the portal flow. So this portal vein is very important. So you see the role of portal vein for the growth of the liver or liver regeneration is important. So by redirecting the portal flow to the part for which we need to hypertrophy, the FLR, so that is the main aim, and portal vein flow is increased in the FLR. It's almost zero in the tissue we want to remove it, the tumor containing tissue. So what happens? This goes atrophied and this hypertrophies. So this atrophies, this hypertrophy, and we remove this part. So this is just a schematic, like the most of the tissue which is around the portal vein. This segment, the one, okay, zone one is the part which undergoes the maximum hypertrophy because it is nearest to the portal vein. Also, these all signifies the importance of portal vein in the regeneration. So regeneration after portal vein embolization is slower than after hepatic resection. Okay, because what happens after portal vein embolization is apoptosis. Okay, so question may be asked: portal vein embolization causes regeneration by necrosis, apoptosis. So answer is apoptosis. Okay, apoptosis occurs in portal vein embolization, and frank necrosis can be seen after resection. Okay. So apoptosis of the tissues is caused. So that's why the regeneration is slower than if you undergo a resection. Now this resection is helpful in a when we discussed ALPS, because resection is a part of ALPS, not portal vein embolization. Okay. So rationale. Why do we need to? I have already told you. Because the Makuchi published the first report of portal vein embolization for inducing hypertrophy of the non-embolized liver segments before resection. Why? Because it mitigates sudden rise of portal pressure and prevents perioperative dysfunction, so increases the FLR. These are the two rationales. Okay. So YPV, it is a safe procedure, zero procedure related mortality. Okay, we haven't in our settings or nowhere, it's usually not seen. It's very, very, very rare to have an mortality due to portal vein embolization. Okay, a patient with this has undergone portal vein embolization and a patient has died because of portal vein embolization. That has not been seen. I haven't seen it, and I don't think any one of us have seen this. It may have happened, but we never have heard about it. And 50% shows no change in LFTs. Okay, you are like embolizing the portal when you are cutting off the supply. Even after that, the LFTs remain stable. Only half show slight fluctuation with return to baseline after 3 days. So it is so much safe procedure. It is well tolerated also. Unlike TACE. So if you know about TACE, TACE is a procedure okay, where chemotherapy is induced, embolization material is also introduced into the hepatic artery so that to kill the tumor cells, HCC and all. So what happens after that? Due to this chemotherapy, chemo material and embolic agents, it's like pain, fever. These are the most common symptoms, and people do present with recurrent pain, fever after taste. But that's unlike with portal vein embolization. People usually don't have any symptoms. So it causes apoptosis, already told you, rather than ischemic necrosis, thus limiting inflammatory signals. So, see, I have already told you assessment of FLR. So, both FLR should be proper in terms of volume also. It should be proper in terms of function also. So, volume we calculate with the help of a multi-phase CT, even MRI. Okay. And remnant function by ICGR 15, hepatobiliary scintigraphy, technetium 99 galactosyl human serum albumin GSA scan, or methacetin breath test, Limax. I've already told you this before. This is just a reminder because this is FLR is important in this topic. So we have already told you the size is just not enough. You need to have the function also. And yes, standard FLR is more important than the standardized FLR is more important than the FLR. And I already told you how to calculate the total functional liver volume. This is by the WADI, and we don't need CT or MRI in that. We can just calculate it by simple basic numerical formula. These things we have already discussed before in our slides, so no need to go into details as of now. Just a brief idea what is FLR, what is important. Now, what factors decide like which patients will benefit from portal vein embolization? A patient comes for hepatic resection, not everyone goes through portal vein embolization. What is required, what patients need, and what is the indications for portal vein embolization? So first is the extent. Yes, extent is very important. If you are removing a single segment, or if you are removing even the left lateral lobe or even the left lobe, because I already told you, right and left are divided into, this is around okay, there have been 17 to 45%, and this is around 50 to 80%. Okay, 50 to 78% around. It's not 17, I think it's 20. So see, this is the ratio which has been seen. So right is always more than the left. So if you can remove the left also safely, if the tumor is in the left part, so even in that, sometimes you don't need any sort of augmentation, any sort of augmentation. the liver volume is sufficient enough to handle that remnant volume. So the extent of resection is very important. Okay. So there comes the FLR. FLR percentage, FLR volume. Mostly these ALPPS and portal vein have been described when we are planning for a right trisegmentectomy, trisectionectomy, trisectionectomy, or a left trisectionectomy, or an extended right or an extended left. Okay, extended right or an extended left, where either a right posterior segment is remaining in this, or in extended right only left lateral segment is the FLR. So these two are very small in volumes. So we need to augment these. So the extent of resection, if it's very high extent, then only we need to think about portal vein embolization. Okay, we need to have baseline LFTs. We need to know the ICGR15 value also, so as to calculate the function. Okay, the extent of liver injury, the age and comorbidities, these are all the factors which decide which patients benefit from portal vein embolization. So we'll go into detail about it. If the ICGR value is more than 10, okay, that means there is a decreased reserve, and we need, even if the FLR is sufficient, or we can say FLR is at the borderline, like 30 to 40%, it's like 30%, okay, and you get an ICG of only of more than 10, or you get like 15, 20, so you cannot sit upon it. The FLR 30 might not be sufficient in that, because that means some things like the hepatic parenchyma dysfunction is present. So we need to increase the FLR. Otherwise, that 30% will not be sufficient. So ICGR 15 and more than 10 indicates decreased hepatic reserve. So this is not good. If it's less than 10, no need. With normal liver function, as low as 10% will support, but this is very, very controversial statement. Don't remember this value. Okay, don't remember this value. I say you don't remember 10%. Even you don't remember like 20 to 25%. Okay, with the normal liver, remember it's around 20 to 25% if the FLR. Then various studies have shown there is very less risk of post-op complications. Okay, and with this, some type of liver injury is there, like steatosis is there, and there should be a chemotherapy of more than 3 months. What chemotherapy I have already told you. So this is like irinotecan. So then you need an FLR of around more than 30%, and PV is indicated if the FLR is less than 30%. If the patient is cirrhotic, then you need PV if the FLR is less than 40%. Prolonged biliary obstruction, same as cirrhosis, PV if FLR less than 40%. So this is a very simple diagrammatic description defining the desirable FLR in each condition. If the normal, then if the liver is normal, then 20%. If the liver is some type of injury is there with the chemotherapy, or it's fatty, it's steatotic, then you need 30% of the FLR. If it's cirrhotic, or if it has biliary obstruction for a prolonged time, then you need around 40%. Okay. Coming on to contraindications, okay, in which conditions we cannot do a portal vein embolization? Absolute contraindication is a portal hypertension. If you have features of varices, if you have ascites, if you have splenomegaly, okay, if you have splenomegaly, these all features, or a high HVPG indicating a portal hypertension, you cannot block it. You cannot block it. Why? Because now all the blood will now drain into these collaterals and will increase ascites, cytopenia, variceal bleeding. So please never do portal vein embolization in clinically significant portal hypertension, or extensive tumor invasion of the portal vein, complete portal vein occlusion of other causes like portal vein extrahepatic portal vein obstruction, or portal vein thrombosis of that type. Okay. So in all these conditions, portal vein embolization is absolutely contraindicated. There are relative contraindications like extrahepatic meds. Why to do an extensive surgery when you have an extrahepatic meds? But that is relative. Okay. There are various conditions where we can do like neuroendocrine tumor and all. If there is a tumor in the expected FLR, now this is also controversial topic because sometimes people have even practiced this ablation of this tumor and then portal vein embolization of the part which we want to remove it, and then after some time when the FLR grows, then then a second stage surgery to remove the any visible tumor in that FLR. So this is a relative contraindication. I hope you understand what I'm saying. Even in a tumor present in an FLR, it's not an absolute contraindication. We can do something about it. Tumor blocking safe access to portal vein system is a relative contraindication. Why? Because we have sufficient technical expertise now to tackle these sort of things. Yes, if there is a biliary dilatation, yes. Why this is important? Because mostly these are ultrasound guided techniques which are done to they reach the portal vein directly through ultrasound uh, percutaneously. And if there is a system is dilated, portal vein and bile ducts they travel together in sheath. Okay, so if bile duct is dilated so much that the access to the portal vein is also difficult, you may land up entering the bile ducts, and that may cause some type of cholangitis and all. So this is the thing. Biliary dilatation is a relative contraindication. Mild portal hypertension is a relative. Severe portal hypertension is an absolute contraindication. Coagulopathy, because why? Because this is a procedure of something you need to puncture, and if there is coagulopathy, then you will end up in bleeding, and that bleeding is might be difficult to tackle. But nowadays it's easy. Okay, they have so much of these glues and all. They all like fix the whole track. They all glue the whole track, and they come out, and you won't get any bleeding post procedure. Renal insufficiency is a thing. It's also a relative contraindication. So, how to do it? How to do a portal vein embolization? There are some things like it can be performed in moderate sedation or even general anesthesia. No consensus on the use of prophylactic antibiotics, but everyone does it. Okay, everyone gives it. No one takes a chance. Goal of portal vein embolization is complete occlusion of the targeted segments. Okay, so if you are planning a right, so if you are planning like removing this part, you want to remove this, then this is supplied by the right portal vein. So this is the left portal vein, and segment 4 branches also. Segment 4 branches. Now segment 4 branches are usually derived from here. So you need to embolize this. You need to embolize this. After that, you get a very good hypertrophy of the left lateral segment. This is segment 2 and 3 portal vein. This only remains, and this supplies the remaining FLR, and you get a very good hypertrophy. Okay. So, yes, this is also important. You need to embolize the entire portal tree, including the distal branches, to prevent portoportal shunts. Okay. So, there, see, if you just do it here, then they might form connections here, and you might not get that much hypertrophy. So, approaches, okay. Surgical, which is not usually done nowadays, very rarely done. No one opens up the abdomen and goes to the ileocolic vessels and then reaches the portal vein and embolize the portal vein. This is very rarely done, but still, this is a procedure. So it can be done surgically. Now, this is very the most commonly approach of portal vein embolization is the percutaneous transhepatic technique. So you go directly into the liver through the skin, ultrasound guided, and you reach any branch of the portal vein, and then you guide the wire through the branch of the portal vein you want to embolize. It can be ipsilateral or contralateral. Okay, ipsilateral means I'll tell you. Okay, so this slide is very important. Transalveolic, it carries the drawbacks of an invasive procedure in general anesthesia. I just wanted to tell you what is the drawbacks and advantages of all these techniques. So I told you ipsilateral and contralateral. So ipsilateral means through the tumor bearing liver. Okay, this is the tumor. You enter here only. You enter here, and then this you find portal vein somewhere here, and you embolize that part. Advantage is you are not damaging the FLR. You are not entering through here. So you are not damaging the FLR. And the disadvantage is the right segment embolization can be challenging. Why? Because then you have acute angles. You have acute angles to go to the segmental branches. Reverse catheters are used. Also, when you go through the part which has tumor, you can cause peritoneal seedings. Opposite is opposite true for the contralateral approach. For the advantages, it's very easy. It's not like if the tumor is here, you are going through here, then you have an easy access. You can easily access this part. You don't have acute angles to go. So this is very easy manipulation. Okay. Deployment of embolic material in the direction of the portal vein and not opposite to the direction of the portal vein, and also avoiding puncturing of the tumors. So no peritoneal seeding. But now here you are damaging the FLR. Okay. So which is one of this is better? There is no consensus as such. But this approach is usually propagated. The ipsilateral approach. FLR is very important for everyone. You don't want to damage the FLR. Everyone, each and every HPB surgeon fears PHLF. But they are like they cannot sleep if PHLF happens to any patient. So peritoneal seeding is like zero point 0.1 to 0.5% only. Okay. So but the risk of PHLF is real. Okay. So we don't want to do anything with the FLR. So this is ipsilateral approach is usually preferred and usually done. But as such, there is no literature which one is better, which one is not. Okay. Both of them are done regularly, whatever the need arises. Okay. Moving on. So what type of embolic materials are used? Gelatin sponge powder plus iodized oil, absolute ethanol, and N-butyl cyanoacrylate, polyvinyl alcohol, microsphere, sodium tetradecyl sulfate. All of them have been used, and this no consensus regarding the standard embolization agent, which is best, which is the best. There is no standard. Okay, all of them are used in day-to-day settings. I think in our center most commonly used was gelatin sponge powder. I'm still not sure, but I think they use gelatin sponge as well as this polyvinyl alcohol. Okay, so this is a procedure which has very less complications as such. Major complications you see, all the rates are less than 1%. Okay, like major complications are portal vein thrombosis, which can be devastating. Embolization of non-target vessels. You are embolizing those vessels which you don't want to. Okay, hematoma because you puncture the liver directly. Infection, abscess. and intra-abdominal bile leakage. All these are major, but see this ratio, the percentage are even less than 1%. So it's portal vein is a very safe procedure. Okay. Minor complications like fever, elevation of transamnitis, I have already told you, in around one third of these patients. In around one third patients. Okay. So, some complications of portal vein embolization are similar to other transhepatic procedure like hematoma, hemophilia, hemoperitoneum, vascular injuries, pneumothorax, cholangitis. And complications occur more in the punctured lobe. The lobe which is punctured that has more complications. So therefore we usually do. So we usually prefer an ipsilateral approach. And complication rates after portal vein embolization higher in patients with CLD. So nothing much about it. Okay, how to assess response? The hypertrophy response, the percentage of volume increase is the post PV minus pre PV upon pre PV in 200, or degree of hypertrophy. This is not atrophy. This is wrong. Atrophy is this. This goes here. So degree of hypertrophy is equal to the percentage of FLR post PV minus percentage of FLR pre PV. And if DH is more than 5%, okay, that means your portal vein embolization is good. It's good. You have done an sufficient hypertrophy. And the degree of hypertrophy expected after portal vein depends on the degree of underlying liver disease. I've already told you in a patients with cirrhotic, they have a poor regenerative response, poor regeneration. So even after portal vein embolization, they will regenerate poorly. With a normal liver, they regenerate at a rate of uh, 12 to 21 ml or centimeter cube per day, with compared with 9 centimeter cube per day in cirrhotics. Okay, so 12 to 21 and 9. This is the change per day change. So at around 2 or 3 weeks, you can see such a large difference in both these. This is almost half, almost half. The average comes here around 16 or 17 or 18. This is almost half. So cirrhotics, they regenerate very less after portal vein embolization. So in normal liver, sufficient hypertrophy occurs within 2 to 4 weeks, whereas regeneration in patients with cirrhosis can take more than 4 weeks. So yes, so timing is not always 2 to 3 weeks. If there is insufficient hypertrophy, we need to wait more also. So in cirrhotics, you need to wait more, even up to 5 6 weeks. Okay. And kinetic growth rate, this is also a term which has been described, and remember this value 2, kinetic growth rate more than 2 is more accurate predictor of PHLF than SFLR or degree of hypertrophy. So kinetic growth rate is very important. Kinetic growth rate. This is nothing but percentage of hypertrophy upon time. Okay, time. This time is mostly in weeks. So more than 2% is like good. It predicts a occurrence of PHLF to be less. If kinetic growth rate is less than 2%, then the PHLF chances increases. So this is the cutoff you need to remember. For degree of hypertrophy is 5% and kinetic growth rate 2%. Okay. So this is what was for portal vein embolization. I think I have covered almost everything, and I don't think any other questions has been asked from portal vein embolization. Just go through the slides. These are very interesting, well formulated slides and painstakingly made. So I don't think there is anything extra you need to read about portal vein embolization, and most of the questions can be answered from it. Moving on to ALPS, which has the same goal to increase the FLR, but a certain different approach. Most important question which has been asked in ALPS is what is the full form of ALPS? Okay, many a times I have seen. So this is associating, associating liver partition and portal vein ligation for staged hepatectomy. So this is what is important: associating liver partition with portal vein ligation for staged hepatectomy. So this is the question which has been asked multiple times, and it can be like they can put anything associating, or I don't know what type of questions they might ask, but this is the term which you need to remember, the ALPS full form, which has been asked multiple times. And the story behind it is very interesting. Okay, this has been recently, only recent. The concept of ALPS is not uh, old. It's quite new, and only in 2007, like only 15, 16 years have passed. This hence Dr. Hans Schlitt is a surgeon in Germany. So he was performing a right trisegmentectomy or a extended right hepatectomy for cholangiocarcinoma. Okay, for cholangiocarcinoma. So during the operation, while he was transecting the plane, he had already ligated the portal vein, and he was transecting the plane between the segment 2, 3, and segment 4, like at around the falciform ligament. So he found that the FLR which he was to leave behind is not sufficient. He abandoned the procedure. Okay, he thought after removing this part, this liver will be like this much small, and definitely the patient will go to PHLF. So what he did, he like left the patient in that position itself. He did not remove the specimen. He just like he had already ligated the portal vein. He has almost also resected the total like the plane, the parenchyma, but he still did not remove it because he thought that the segment which he was about to remove is still having its arterial supply. So some part of hepatic function might be carried on from this part also. So PHLF is a very dangerous situation. Let's not go into it. He closed the abdomen. 9 days later, what he found was that that liver, the left lateral part, has grown to around 80 to 90% of its original volume. He went again into the abdomen and he removed the tumor containing part. So that's how he discovered, and he put a paper about ALPS. So serendipity, it's like a serendipity only. So what is ALPS now? Okay. So there are very two important things is there. Liver partition. That means you need to have resection. The liver is resected. Resection is there, one part. Other part, portal vein ligation. So you close the portal vein you ligate it or you embolize it. So these two parts form ALPS. Okay, now, and the other thing is staged. It is not done in one stage, it can be done in two stage, three stage, four stage. Usually we read about is two stages. So not stage two, two stages. So it is a staged hepatectomy. You do not complete this procedure in one sitting. So the full form of ALPS, if you just focus on it, then you can understand what is happening in ALPS. So what happened? In 9 days. I told you, in 9 days the liver grew 90%. So in portal vein embolization, we usually wait for around 2 to 3 weeks, which is around uh, 21 days, 20 to 21 days. And here only in 9 days, we get an hypertrophy, so much hypertrophy that we can remove the tumor on the ninth or the 10th day. So you see, the rate of hypertrophy is very high in ALPS as compared to portal vein embolization. So the rate of complete tumor resection has been shown to be higher after ALPS than after two-stage hepatectomies or portal vein embolization and ligation. But the problem is, see, you have to do surgery twice. So there is very high post-operative morbidity and mortality. So you need to select the patient very well. You need to monitor the patient very well. You need to have interstage management of the patient very well. Even after stage one, some patients, some procedures, some ALPS have been abandoned because the patient were not suitable for stage two. So interstage management of these patients is very important. So main indication is, see, colorectal liver mets. Okay. So ALPS is usually done in nowadays is most commonly done in colorectal liver met. It's not limited to CRLM. It has been done in cholangio, hepatocellular carcinoma, but usually it's done in CRLM because these CRLM are mostly bilobar. Okay. And ongoing trial, if you want to, ongoing or the recent trials on colorectal liver mets for ALPS is the LIGRO trial, which has compared the efficacy of ALPS versus portal vein embolization, portal vein ligation or embolization for colorectal liver mets. Okay. So LIGRO trial. Remember this name, LIGRO trial. So, what is the procedure which we do in stage one? The tumor bearing lobe is deportalized. That means if this is the liver, this is the tumor, and this is the portal vein. In the first surgery, when you open the abdomen, you ligate the portal vein here. Okay. But you preserve the arterial supply, artery is preserved, the bile ducts are preserved, and the hepatic veins are also preserved. These are preserved. Only the portal vein is ligated. And the other thing which is done in stage one is the transection of the parenchyma. You don't remove it, you just transect it and you close the abdomen. Okay, now this has been asked कि FLR is cleared of tumor in stage 2 or stage 1. FLR is also, if there is small part is here or some part is here, small tumor is here, you remove that part in stage 1 itself. In stage 2, nothing. All the parts which have been left, artery, bile duct, hepatic veins, that are tied, tied, and then the whole part, this part is removed. And by that time, stage 2, this must have had sufficient hypertrophy. So simple. Okay. Now questions can be asked in various forms. Which of the following is true about stage one or false about stage one of ALPS procedure? Artery is ligated, hepatic veins are not ligated, bile ducts are not ligated, but portal vein is of the left portal vein is ligated. So, see, you need to remember the basic concept and you just have to apply your logic there and you can answer all the questions. The examiner, they just want to test your basic knowledge. They don't want you to remember what paper, what year, what that, and what not. Because they can frame question in a number of ways. But the simple concept is that you just ligate one thing, that is the portal vein which has the tumor, and you transect the liver. This is stage one, nothing else. You don't touch anything. Okay, in the next part, you just remove all the connections to that tumor containing part other than the portal vein, because the portal vein has already been ligated in the first stage. That is the bile duct, the artery, and the vein. That's it. Simple. This is the two-stage ALPS, and it can't be simpler than this. Okay, these all lines, everything has been taken from Blumgart, and they have very nicely explained the procedure. I have put on some diagrams. These are all diagrams from Blumgart itself for you to understand what ALPS actually is. So in stage one, see stage one, there is ligation of the portal vein. There is a ligation of the portal vein together with the liver parenchymal transaction. Okay, getting it? Can you see this portal vein? Can you see the tide of portal vein here? This portal vein has been tied up. Okay. Okay, results after stage 1. See, the tumor was this much big. It has shrunk now. Left lateral was only this much. It has grown this much. And at the end of stage 2, you remove this part, you get a hypertrophied left lateral. You preserve all the supply of this. You preserve the outflow of this, but you remove and ligate. You have cut it here, cut all the right portal vein, right hepatic vein, the right bile duct, and also the right hepatic vein here. So this is also same. If you want to read what is done and what is not, you can just read through the diagram. It's very simple, very illustrative diagrams. Okay, so this is the flow chart which is important, and I haven't seen a question. Frankly, I haven't seen a question asked from this, but this is very important for doing an ALPS for in our clinical settings. And this is this it's ALPS is not just stage one, stage two. You need to manage that patient also. You need to understand which patient should undergo what. You cannot just after 7 days go and open it again and remove the tumor. What if there is insufficient hypertrophy? Okay, what if the function of the liver, the function of the FLR which has grown, which has hypertrophied, is not sufficient? We need both volume and function. So the interstage management of all these patients are very important, and we need to analyze it also and time the second stage of the surgery well. So this is what is the flow chart, the algorithm which is used in ALPS procedure. So what is here? See, indication. What is the indication for ALPS? Like if the FLR, or if less than 30-40%, or if, according to if FLR upon body weight is less than zero point 0.5 to zero point 0.8, plus the tumor margin is close to FLR, very close. It's a bilobar disease, and you need a very high degree of hypertrophy, more than 65%. And hepatobiliary scintigraphy, this is the academic medical center in Amsterdam. So HBS AMC value is less than 1.7 minutes per meter square. What is this actually? This is the FLR uptake, the hepatobiliary scintigraphy. You see the some hepatotrophic agents are given, and we see the uptake of those agents by the FLR uptake. So if the FLR uptake is less than 1.7 per minute per meter square, that means that FLR is not functioning very properly. So this is a cutoff. This has been through various studies and all this. This value has been put forward, and now we know there is a consensus. If it's less than 1.7%, that means the FLR is not functioning that well. Okay, so these are all the indications for ALPS. And failure of portal vein embolization, we have already tried or already done, and insufficient hypertrophy has been seen. So we do stage 1. Then on day 6, we do a CT volumetry, also hepatobiliary scintigraphy. If the FLR upon total volume is more than 30 or upon body weight is more than zero point 0.5 to zero point 0.8. Also, if this is HIBA scan, this HIBA scan is actually Hospital Italiano Buenos Aires de Buenos Aires index. If it's more than 15%, and same thing here, if that AMC index, which is the HBS index, is more than 2.7, then after doing a interval as clinical assessment, and if all things like good condition, no PHLF, no complication, MELD score less than 10, if all these things are justified or satisfied, then you go for a stage 2. Else you delay it further. See, only this, if you follow this path only, then only you reach here. In all these, you don't reach here. You're not reaching it here. So, not in every case, not every patient goes to stage 2. We have to abandon it sometimes for the betterment, or for or delay it, mostly delay it, not abandon it, mostly delay it to more than 7 day, 10 days, 20 days, even 3 weeks, 4 weeks. Because we have to satisfy all these criterias. Okay, this is HIBA index is around 15%. These are all nothing. These are all, they have been taken up from hepatobiliary scintigraphy and SPECT CT. Okay, both of them are done together, and these two are like various indices. Buenos Aires, like Argentinian index, AMC or Amsterdam index. So they have formulated some index, some based on some calculations, and this is this value they have come up with. If these values are satisfied, then we go on to stage 2, else no. Okay, so you read about this. This is a very good chart. I just wanted to tell you how do we proceed forward. We have done stage 1. Then on day 6, we do a scintigraphy, CT, SPECT CT, and we check for the FLR in augment, like hypertrophy. Also, the uptake of the hepatobiliary agent into that FLR. The function and the volume, both are important. If both of them satisfy, and if the patient condition is good, he is tolerating the procedure, because now he has to undergo a second surgery, which is also major. So if the condition is good, no PHLF, no complication, then you go for ALPPS stage 2. Okay, now the question, the slide which can get you maximum number of question is this, because one word answers, question answers are very like a loved thing of NBE. So this is the MCQ slide. No need to understand or anything, just mug it up. So ALPPS is portal vein ligation, complete transaction of the liver parenchyma. It's a classic technique. Partial ALPPS or P-ALPPS is portal vein ligation. Incomplete transaction, but still more than 50%. So how do what is the need? What is the justification? It reduces mortality. ALTPS, portal vein is ligated, partial transaction is done, and it's occluded by tourniquet. The use of tourniquet is the T here. RALP, radiofrequency associated liver partition. Its ligation, portal vein is ligated, the liver parenchyma is transected completely, and radiofrequency induced necrosis is there. This partition is done with the help of some radiofrequency device. Hybrid helps, we don't do ligation, we do embolization. Okay. And the parenchymal transaction is completely done with surgery, not by radiofrequency. Mini helps, hybrid, mini, partial, these are all confusing. This can confuse you. Mini helps is very mini. It's even minier than partial. So it's only portal vein embolization, not ligation, partial parenchymal transaction. Partial type or ALPS, it's trans-ileocholic type is trans-ileocholic portal vein embolization and partial parenchymal transaction. So this is the slide where you can get maximum number of questions. So please mug it up in anyhow you want to remember it, whatever formulae or whatever mnemonics you want to make it. I want to tell you one thing. Partial is remember these two uh, like at once. Partial is nothing but incomplete transaction, and mini is minier than partial. If T is there, then that's tourniquet. R is there, then RFA. Only thing is this type you can understand it's trans-ileocholic. So this is not through the skin or through transhepatic. It's trans-ileocholic. This can be easily remembered. Most is hybrid. Most like which can get you confusing is hybrid. Whether it's incomplete, complete, mini. So hybrid is embolization. Remember, hybrid is embolization, same as ALPS, same as ALPS. But mini ALPS, sorry, mini ALPS. But mini is very mini. So partial transaction, but hybrid, complete transaction. See, that's how I remembered it. I know I must be sounding confusing in between, but you have to formulate something so as to remember it in your exam. And this slide will get you MCQs. Okay. So go through it once or twice, you will get the gist of it. This is just a brief history, and if you want, you can read it. I have already told you this. You don't want to like, if you don't want to waste time in it, you can leave it also. So, coming on to the mortality and morbidity, so we see the mortality has been decreasing in the last couple of years, as that with any type of hepatectomy we are doing. So mortality has been very less in the last couple of years, but morbidity is very high. Okay. Earlier it was around 50%. Now it has come even after stage one, it come down to around 20 to 25%. And after stage two is also around 20 to 25%. So this morbidity is significantly higher. Like in every one third of the patients suffers from some part of some morbidity after stage one and stage two. So in fact, in at present also it is a morbid procedure. So we need to be very careful in planning the procedure, and we have an algorithm with us. Okay. So this is all about portal vein embolization and ALPS. I hope you like the slides. I hope you like the content, and I am very hopeful that you will be able to answer all that is asked in your exams. Mostly two or three questions you might get from both of these topics. And ALPS is very important. ALPS is the favorite nowadays, and you can get one or two questions from it. So I think we have almost completed our liver part. We'll be moving on to the pancreas, then the biliary part. Pancreas and biliary will be covered in five to six topics each. So, so let's see you in the next class. I think if I find some important topic, I can place it in a miscellaneous lecture. So I don't think anything else has been asked in the exams as of now. So let's finish this class right here, and we'll be moving on to the pancreas in the next lecture. Thank you.